Hello. Today we're going to be talking about the assessment process. We're in Chapter 3 of Comer, Clinical Assessment, Diagnosis, and Treatment. If you were a client going to see a mental health professional, most likely the first thing, or one of the first things they would do with you, is to sit down with you and get to know you and learn about your concerns and your life. The process of doing so, of course, is called a clinical interview. And clinical interviews are probably the most common assessment technique that clinicians use. As you'll discover from reading Chapter 3 in Comer, there are a number of other assessment approaches that can be taken with clients, and we are going to talk about a few of these today. Regardless of the assessment technique that's used, it's always important to think about how reliable and how valid is that instrument or approach. So let's talk a little bit about reliability and validity. Reliability refers to the consistency of a measure. There are two types of reliability that are important for us to consider. One is called inter-rater reliability, and the other is called test-retest reliability. With inter-rater reliability, we're looking at the consistency of the measure when taken by two different professionals on the same client. We would hope that if those two different professionals examine the same client using a particular instrument, they would come up with similar findings. Interestingly, oftentimes that's not the case. So reliability scores are reported as correlation coefficients, and the higher the correlation coefficient, the higher the inter-rater reliability. The other kind of reliability that would be important with some measures is what's called test-retest reliability. And here we're expecting that if we were to take a test today and we took it, say, 2 weeks from now, depending upon the test, we would expect to get highly similar results. A good example of that would be IQ tests, which are discussed in your chapter. We wouldn't expect IQ to vary a lot from week 1, say, to week 3. Assuming that the conditions of testing and the state of the individual taking the test were highly similar between those two testing dates. The other measure of an assessment instrument that's important to consider is validity. And validity refers to the extent to which a measure is measuring what it says it measures. For example, if someone took a test for depression, we would hope that the test really was measuring depression. And if the test is high in validity, then we could be more confident that our results would be reflecting what's going on with the client as far as depression is concerned. So there are different kinds of validity, and two in particular that I'd like to talk with you about are what is called concurrent validity and predictive validity. In the case of concurrent validity, one measure of a particular problem is highly correlated with some other measure of the same problem that already has well-established validity. So let's say you wanted to develop a new scale to measure depression. And the advantage of your new scale is that it was shorter. It didn't take as long for the client to complete it, and it wasn't as costly. So before you would publish your scale and make it available, you would need to establish its concurrent validity. And a great way of doing that would be to give your scale and another well-established scale, possibly longer, more detailed, with well-established validity, to the same clients, and hope that they got similar scores on both scales. That is, if they had a high score on your scale, they also had a high score on the other well-established scale. If that were the case, then you would be establishing concurrent validity, again expressed as a correlation coefficient. The other kind of validity I wanted to comment on is predictive validity. And predictive validity has to do with the extent to which a measure predicts some future behavior or event. Let's say, for example, that you wanted to develop a scale to predict suicide, which is, by the way, an extremely difficult event to predict because it occurs so rarely. But let's say you're trying to develop this scale anyway, and not only are you developing the scale to predict suicide, but to predict perhaps even more importantly, when people are at risk for suicide, or those people who may be more likely to become at risk for suicide in the future. For example, you go into a high school environment and you want to identify vulnerable or at-risk students with regard to suicide. If your scale does a good job of identifying those kids who at some later date may have thoughts about suicide, for whom you could intervene even early before that happened to help decrease the risk of suicide, that would be a great service to teenagers throughout the school systems if you had such a scale that you could use in that setting that would produce that result. So those are the two kinds of validity for us to be concerned about. There's a little more about validity in your chapter, but those are the two I wanted to talk with you about today. So you'll see in reading your chapter that there are a variety of different assessment methods that can be used in evaluating clients. Many of those methods would not be used with the typical, say, outpatient client who would come in for counseling or therapy. But depending upon the circumstances and the setting, say inpatient versus outpatient, medical versus behavioral health or mental health setting, and age of the client, school system versus hospital, various kinds of considerations. A variety of different assessment instruments might be used. With the clinical interview, again, by far being the most common method that would be used in outpatient settings, and even in other settings, it would most likely be a part of the assessment process so that you can get to know clients in a more personal kind of way. Clinical interviews can vary in how structured they are. Sometimes they include a mental status exam, which is a more detailed description of the client's thoughts, emotional experiences, and behavior, and sometimes not. But the clinical interview does give us a sense of what's going on with the client. Because there is some subjectivity involved in the clinical interviewing process, then we have to be concerned about what those implications are for both reliability and validity of that approach. So for our purposes, another kind of assessment approach that we want to talk about a little bit is how to assess personality. And there are basically three different ways of going about assessing personality that are described in our chapter that I wanted to briefly talk with you about. Projective test, personality inventories, and personality response scales. So projective inventories are tests like the Rorschach inkblot technique and the thematic apperception test. You'll see pictures of them in your chapter. The Rorschach projective technique, of course, involves using ink blots, and the thematic apperception test involves having clients look at sort of ambiguous pictures of people in different sorts of situations and tell stories about the pictures. With the Rorschach projective technique, you would ask the client to talk about what they're seeing in the pictures, what it looks like or reminds them of, and what about the picture makes it look that way to them. Based on their responses, then the administrator and interpreter of the responses would try to come up with some statements about the personality of the individual completing the test. Well, as you can see, there's some subjectivity involved with all of that. Even though there are some objective scoring systems, there's still some subjectivity. And one of the big criticisms of all the projective tests, including the Rorschach, is that they aren't as reliable or valid as the more objective personality tests are. Yet, historically, they have been used probably more in the past than presently, and some people believe that they are still quite valuable instruments. With the thematic apperception test, you ask the client to tell a story about what's going on in the picture, what the people in the story are thinking and feeling, what led up to what's going on in the picture now, and what the outcome may be. And based on these stories, the clinician identifies themes that may help shed some light on the individual's personality. Objective personality inventories, like the Minnesota Multiphasic Personality Inventory, are paper and pencil tests that allow you to obtain measures on a number of different dimensions of personality and psychopathology. By far, the Minnesota Multiphasic Personality Inventory is the most widely used objective personality inventory of psychopathology in the world, and it has been translated into various languages. There is a wealth of data now on the MMPI and different kinds of what are called profiles that people may generate when they take the MMPI to help us better understand what it might describe and predict about personality. You might take a look at it in your chapter and some of the different scales that are included in the MMPI. There are other objective personality inventories around, but that's the one we're going to focus on today, and that's the main one that's focused on in your chapter. Another kind of personality test that sometimes is used, and they're pretty popular, is the kind of test that's just measuring one particular personality area or problem. Say a test that's measuring depression or anxiety or maybe suicide. These tests are called response inventories, and they're very popular in part because, well, some of them are quite reliable and valid, and they don't take that long to administer, and they can help you to evaluate where a person is before therapy, during therapy, and after therapy with 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 retesting with those particular instruments. Uh, Three that are particularly popular, all developed by Aaron Beck, a cognitive therapist that um, we'll be learning more about. He has one for depression, one for anxiety, and one for suicide. But then there are various other inventories of that nature that are out there and that are available. The other kind of assessment method that I wanted to mention today is the use of neuroimaging. This would be things like CAT scans, MRIs, and PET scans. These are very fascinating instruments to use to actually look at what's going on in the brain itself. In the mental health field, I would say they're used more for research probably than in clinical situations, although there are some clinical situations where people might be asked to take one of these neuroimaging tests as well. Say if someone is suspecting some sort of brain damage, tumor, or degenerative process or something of that nature. So I would encourage you to read about these different neuroimaging methods that are used and give that some thought. Probably a lot of you have had, not necessarily on your brain, but some part of your body like your knee or something else, one of these neuroimaging methods used before, and you would have some familiarity with them. So that's a little bit on some of the assessment methods that are used. There's a really interesting discussion in your textbook about the process of diagnosis using the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, or DSM-5. So I wanted to talk with you just briefly about that. The DSM-5 is the main diagnostic system that's used in the United States and in some other places for assessing and making determinations about diagnoses of psychological disorders in clients. The DSM has been around for several decades now. When I went to graduate school, we were in the DSM-3, so every once in a while it gets revised and updated, and now we're in DSM-5. A couple of interesting things that happen with each update are that new diagnoses are added, and sometimes diagnoses are eliminated or changed in the way they're characterized. A good example of a diagnosis that's been changed over time is what we now call attention deficit hyperactivity disorder, or ADHD. There was a time when ADHD was not in the DSM, but rather someone having the same symptoms were given the diagnosis of minimal brain dysfunction. Another interesting example is there was a time when homosexuality was in the DSM. It is no longer. So these are, we could come up with many other examples of changes that have taken place in the DSM over time. But one thing that's fairly consistent is every time they come out with a new edition, they've added more disorders. So now there's over, last count, I believe, 500 disorders in the DSM. Now, when we look at data on prevalence, lifetime prevalence of psychological disorders, and thinking about that in relation to the DSM, over the course of our lifetime, when we aggregate all people, about half of us will experience a psychological disorder at some time throughout our lives, and we would be able to find that most likely in the DSM-5, whatever it might happen to be. So there's a fair amount of controversy about the DSM. Should we even be using it? Is diagnosis relevant? Can it sometimes do more harm than good? And I would encourage you to read this section about the DSM and give all that some consideration. I will say that if you are going into a mental health field and you become a graduate trained licensed mental health professional one day, you will have intimate familiarity with the DSM by then because you'll study it in graduate school in much more depth, and will have some facility in being able to make DSM diagnoses. It is necessary for helping people use their insurance, and it can also have some clinical utility in that there is a fair amount known about different disorders and their causes and treatment and how to effectively help people. So having a sense of where a person is in terms of diagnosis can be useful. Also, it's a shorthand way of communicating with other professionals about some aspects of a client's experience. But we always need to be reminded that a person is more than their diagnosis. And one of the limitations of the DSM is that it does not focus that much on a person's strengths. Now, one of the things I like about the Corcoran and Walsh supplemental textbook that you have is that when you actually do your case studies and you follow the format that's used in that book for analyzing your cases, they do give some attention to clients' strengths, which I believe is very important, that we can understand those strengths and also give the client feedback about them in a way that can be empowering to the client, not just focusing on problems. And finally, there is an interesting discussion in the chapter about psychotherapy and does it work? And the good news about that research is that we can say in a general sense, yes, psychotherapy works. And people who take advantage of psychotherapy and other treatments like medication are usually better off than those who don't take advantage of treatment. Sadly, many people go untreated without getting help, perhaps for financial reasons or because of stigma or fear. And I believe we all have a responsibility to shed light on this area in the way we live our lives and how we conduct ourselves professionally and conversations that we have with other people, so that we can help to decrease the stigma of mental illness and increase accessibility of services for people who can really benefit from them. And finally, I just wanted to say that there is an area of research that's discussed later in the chapter, looking at what are some of the commonalities in different kinds of therapy that help people to get better. This includes looking at the particular type of therapy that's used, the characteristics of the client, and the characteristics of the counselor or therapist. And it's not surprising to learn that different therapies, even though their methods vary, also have some common features in terms of the importance of the relationship between the client and the counselor or therapist. So I'd like to ask you to give that some thought to as you read chapter 3 and think about what are the ingredients in a therapy situation that help that therapy to be more likely to be successful, so that the client can truly gain a better understanding of themselves, of their strengths, learn to cope more effectively, get to a better place in their lives, and to be better able to recognize if they're starting to have difficulties in the future, so that they are more likely to take constructive actions to help themselves before it gets worse. That's about all for now. So I'll be talking with you again soon.